the best and hardest parts of parenting, some ideas that we've had here about how to incorporate discussion of parenting into well child visits as a strategy for primary prevention. And I'm going to be presenting some of the data we actually have. And this is my conflict of interest slide. And as you know, Barbara, my spouse, and I do have a conflict in that we are the co-founders of Chattis. And in this discussion, we will talk about the data that we've obtained through Chattis and some initiatives, but this approach is something that can be done outside of Chattis in a simple way that we'll address that also. Talking about is actually the goal of Bright Futures. So if you read that big tome of Bright Futures, they say that this is all about supporting a life course in which the strengths and protective factors outweigh the risk factors, and to actively promote strengths and protective factors. So that's the goal we're given for checkup visits. And I just note here and come back to this, pediatric well child care has some competition out there. There are minute clinics in the pharmacy. They're offering immunizations. And when families think that that's what these checkup visits are, they can go in a few minutes and have it taken care of. But I don't think the minute clinics are taking on the goals of Bright Futures. And but we want to be sure this is something that can be done, maybe not in a minute, but in a practical way in pediatrics. And that's what we're going to be focusing on today. And there has been a lot of interest, and I think everyone has heard about these ACE studies, adverse childhood experiences, that have influenced how an individual's emotional development will occur, and vulnerabilities, but also impacting overall health. And I think you've heard a number of presentations about that. If you have a number of these ACE factors from both the prospective studies from Kaiser, but also now experimental studies, mechanistic studies show this is real. And so there was a multi-year task force led by Christy Bethel. There were over 500 experts involved in how are we going to address ACE in pediatric visits, and at the same time foster positive social and emotional well-being. And the conclusion is that we need to have a paradigm shift in healthcare. And this was an article in, I believe it was in Pediatrics. And so how do we go about this? You know, when some of these mandates, there's always a screening test for it. We really, if you notice, while parenting is something that we talk a lot about supporting, there's no screening test for parenting. And the real question we want to address is it possible to even open up the idea that we're going to talk about parenting strategies into the very busy agenda of health supervision visits? And so before we get into our approach, I just wanted to review some general research in parenting. And Dr. Kahneman is a psychologist who won the Nobel Prize, actually, some years ago for really introducing the ideas of behavioral economics. But one of the studies he did is he was trying to track moment-to-moment experiences of parenting and other things, but parenting also. And he asked over 900 mothers to note from moment to moment what was enjoyable and what was not enjoyable And turns out when they listed all of the things they do per day, taking care of children was pretty far down the list of things that are enjoyable for mothers. And it ranked just above housework, but below all kinds of other chores. So the conclusion was parenting is really not a fun activity. But there are other ways to look at parenting. And when you look at the sociologists and psychologists who start to have ratings of parenting as something rewarding, it starts to rank higher than other activities. And then when you start to, there were other studies where they they compared parents to non-parents in a prospective study of couples who, before they decided to have or not have children, if they decided to have children, they were higher actually in stress, but lower in despair, and higher in connectedness, and lower in being lonely. And then we know that, and you've all seen this in your practice, non-custodial parents that feel robbed of something that gives agency and meaning, and when they go to court to fight for their custodial rights and to be more of a parent. So when we're talking about what makes you happy, an experience of parenting in some sense doesn't, we're talking about this kind of moment-to-moment happiness. But there's another kind of happiness, and Dr. Martin Seligman, a psychologist at the University of Pennsylvania, has taken the lead in this area. He calls it authentic happiness. And it comes from he traces it to some Greek origins, and leading a productive and purposeful life. And at the end of life, he notes that when we take stock of our life, it isn't how much fun we had, but what we did with it. That would be the purposeful point of view. So in the long run, parents say they do find it rewarding, and they don't regret having children, even though moment to moment it's really not fun. And then Kahneman's work is relevant and really interesting stuff, where he sees that willingness to repeat activities, even painful medical procedures, and he studied colonoscopies before they were as sedative and so much anesthesia as they do now. And he contrasted experiences like that, but even if you prolong the colonoscopy when it ended not so painful, even if it was much more painful than another experience, it was the way it ended and how it was remembered that seemed to make a difference. So he helped us discriminate between and understand the experiencing self versus the remembering self. And he points out, and I think you could understand this, if you give people a chance to have a great vacation, but they can't have any pictures at the end, they really, and they might be amnesic, but it was a wonderful, they take an amnesia pill. People don't choose to have the vacations, even though at the moment they're very happy about it. But what makes a difference is how it's remembered. So how does all this fit into our pediatric care? And so I wanted to give you a case study. This is I want to talk to you about an anecdotal experience of a mother who was a graduate student. I think it was a psychology graduate school. She's an excellent student. And getting into psychology graduate school is harder than getting into medical school these days, if you've taken notice. And so she was very ambitious, but she thought she wanted to have a baby, and she was going to take time off from the ascendancy of her academic career, to have this baby and to be at home by herself. And so uh, she had the baby, and then she was excited, and then got into the doldrums, seeing these piles of diapers, and she was became down and frustrated and wondered if she was adequate as a parent. And she would say, you know, when she went to these checkup visits, she was quick to find out how much did the baby weigh. So maybe there's some evidence for, is she doing a good job, you know, and how's she doing? And you maybe you've noticed this, that parents are quick to find out how is the weight, and we congratulate them if they have a good weight. Now we're not so sure because maybe that means obesity, but you know what I'm talking about. And they came to the 6-month visit, and this happened before the EMR, because this wouldn't happen now. But she's in the exam room, and the doctor left the room, had to check on something, and left the chart there. So she glanced at the chart, looked at it. She's looking, you know, what can I learn about how things are really going? And she saw in the chart, it said A+ mom, A+. And she was ecstatic. And, you know, she didn't tell the doctor, but she, you know, she felt that this doctor has considered that she is really getting A+ and being a mom, and thinks this sadness seemed to lift for her. And then as the child got into the second half of the first year, and she was enthused and decided to have another baby. And she did. And during this pregnancy, it so happened that she got into placenta previa, and it was a serious problem, and they needed to do a transfusion. And then there was this moment. She looked at the when she was going under, and they said, "What type blood?" And they said, A positive. She said, "Oh no, maybe I wasn't A+ mom. Maybe they were just noting that I had A positive blood." So little things can make a difference in how maybe people feel and what we say, and it doesn't have to be something long, but it can influence parents. So with that in mind, let me tell you about the study that we've done, and this is just a questionnaire that we had come to, and when we collect data in Chattis, we say, what do you most want to discuss at the next visit? And we added some questions. And one was, what's the hardest part of taking care of your child? And that's some question I had learned from Julian Fairholt, who was at the Yale Child Study Center, in terms of getting parents, and I had found over the years, getting parents to talk about things that they might be discussing with their neighbors and cousins, but not the doctor. They didn't think there was the auspices for that kind of question. Seemed to broaden the agenda. And I added, what's the best part? So we can normalize it. So we collected, people were using that questionnaire, and we had about 75,000 health supervision visits from kids 0 to 3. And so these are the questions. And so we had some ideas, and we gave them some forced choices. Below that box, there was a comment box, but these were some from just sort of expert opinion. These are things, Wade smiles at me, going to sleep, what good eater is, things like that. What do you think? Anybody here want to venture what was the most common best part that parents would endorse? Anybody? You may have to unmute yourself if somebody wants to venture a guess. No guesses? Okay, I'm going to reveal. So here are our results. And the best part is smiling. And you can see it peaks, you know, at the first, around birth, there's that much smiling going on, that's responsive, and here it peaks. And by far, that was all the way through childhood. That was numero uno. And playing with them, and it started to increase, and that was number 2. So that may not be a big surprise. There were other things that people endorsed about the best parts of parenting. And then we said, maybe we missed something. We looked and coded the other responses that people had written in there. And then there were mostly things about some general positivity, you know, like this is the best kid ever. You know, like it's, and or some things that we had not had as alternatives related to the growth and development or abilities and the way they interacted. And then the hardest parts of parenting. Does anybody want to make a guess about what's number 1 and 2 in the hardest parts? Any guessers? No? How about nothing? There is nothing really hard. That was an option too. So this is what we found. And it was crying. Well, no, actually, I'm sorry. It was sleep initially. And that wouldn't surprise you. Sleep, and then it trailed off here as you got into toddlerhood and this is the first 3 years of life, right? But then shortly after is crying and fussing, and which picked up as when they were toddlers. And nothing is hard. It's about 18% overall. Now, when we said, now what did we leave out when we gave these forced choices? Not forced choices, they could say other. And what other? And we had really blown it because we didn't put in, I think what a lot of people would, understand, time-life balance, time-work balance. There you are, time-work balance. So we've revised that questionnaire, and that was the main thing that was missing. So, so how do you use this information? So the traditional question is, what's your chief complaint? That's how we organize our healthcare. And now we're asking this other question, and part of it, as I said, we just wanted to broaden the agenda and give them an idea that we're open for talking about all this kind of stuff. And even if there's nothing hard, we're trying to let you know that the agenda is out there for you. But then we felt that you should comment. And so that and doctors, we don't know how they've been commenting, but in a project we're beginning now, we've put some hints in and we're getting our ideas together, and we've tried out some ideas with parents. And so if they're less than 9 months, we might say to crying or fussing, nothing's harder for parents than listening to crying and fussing. Some babies are difficult. The challenge is to respond to their hunger and soothing needs as soon as you can, so they learn to be patient in the future. But it can be very frustrating. Who's available to help you? That'd be kind of idea. The idea being that the attachment literature, but that faster responses that Ainsworth found that early on, they were more likely to wait later on. For older kids, we had some suggestions like, we want our kids to be happy. So when they cry, it feels like we're failing. Tantrums can mean your child has ideas of his own. The challenge is to find out what they mean and need, but still keep rules. How are you doing with that? So it's an opener to have, there are all kinds of things you can talk about in behavior and development, but here's their chief complaint in that area. And some comments, and we're also following this with messages that we're sending to their memory book. And here's one on the positive side. The most common thing was smiling, and that smile's such a wonderful reward for all your hard work. great that you have a happy baby. The more you respond promptly to your child with smiling and taking care and talking, the happier she'll be, and the less she'll cry. So that is some discussion points. And so as we were thinking about how we should respond to these things, we thought, well, we want to do what that meeting, the big agenda meeting said. We want to connect with parents with a broader agenda, and acknowledge that, them as human beings, not just consumers of medical care, and letting them know you're open to actually helping them with a wider range of stuff. And then we wanted to use supportive language for something that's real about the child. And, doctors, pediatricians are good at complimenting. Keep up the good work. Pediatricians, I think, naturally want to comment on and be positive, but to be more specific about something that they also appreciate is an acknowledgement for trying to be a good parent. And doctor begins to get to know the child as an individual that way. And your child's very special. We want to compliment the child. And we want to use empathic language regarding the hard parts and normalizing language. To open the possibility that the child may be at fault sometimes. Some babies are really difficult by their own temperament, and help the parent get off the hook a little bit and be more open to suggestions that way. And then to create challenge statements to provide advice as a choice for parents' own problem solving, not in a didactic or preachy way. So those are the kinds of ideas that we've had about how we respond. So that's the best and hardest. And then on this agenda, at the beginning of the agenda actually, is how do we deal with ACE? Is anybody here using the ACE questionnaire? This is recommended by the American Academy of Pediatrics.
I think Dr. Afan is.
Dr. Afan, are you using ACE? You may need to unmute if you want to talk.
Yeah,
Dr. Afan?
They're not muted.
Yeah.
Christina, maybe you can comment on his behalf if you're listening in.
So we just right now use the ASQs and the M chats.
Okay.
So you're not looking particularly at bad things that happened to the parent when they were growing up. That's what the ACE is about.
Currently, we do not. However, I believe in the near future, that's what we will be using.
Got it. Well, this is timely then for us to tell
Yeah, I know. It's perfect.
how we're thinking about it.
Yeah. So the American Academy of Pediatrics says you should use this questionnaire. And I think a lot of pediatricians are wondering, oh, it sounds like a good idea, but what am I going to do with the answers? So we've taken a point of view that I'm going to present here. What we've said is that there ought to be another questionnaire about parents' positive childhood experiences. We're into the yin and yang here, as we've been saying. That gives a more balanced view of how life has been. And so we've been developing some suggested language, as I've shown you with the best and hardest. And we think that probably about early on, after parents decided that their child's going to survive, and after a couple weeks or so, a 4-week visit, might be a good time to use it. And then I'll show you. So this is the ACE questionnaire, asking about abuse and neglect that they may have experienced, and parents have gone to prison and been substance using and so forth. Barbara, do you want to mention something?
So if you just go back to that for a minute.
Okay.
So this is the tool, these are the questions that were asked by Dr. Felitti, who you've probably heard of since then, because he did it in a very large middle-class practice in Kaiser Permanente in California, mostly middle-class families, but others as well. And what he found was that there was so many patients who didn't do as well as he thought they would do medically, and he was wondering why. So he started this questionnaire, and what he found was that there's nearly a linear relationship between the number of these items that an adult endorses as having happened before they were 18, you can't see the instructions on this particular slide, but what it says is, which of the following happened to you before you were 18 years old? And so these were adults looking back at what happened to them, and you can see that that these are some of these are really terrible things, and like being sexually abused, for example, and others are things in their immediate family environment, like living with a problem drinker or somebody who's using street drugs. So those were the kinds of things that actually were related to later mental health and physical health morbidity. And actually, if you have 6 of these, your lifespan is shortened by 20 years on average.
Right.
So that one just blows my socks off when we talk about that.
Yeah.
So that's where these items came from. We did not invent these. These are the ones with the evidence.
Right. And that's what has gotten this conversation started, that the national conversation and the Academy to recommend using this screen. This is the one that has that evidence. And so we thought, let's add another questionnaire. We looked around for something that would enable parents to report on the positive things that may have helped them. And so we borrowed some items, a few items from a resilience questionnaire. Growing up, would you say your relationship with the biological mother was? And there were choices, good, definitely good, things like that. And
there are negative options too, by the way.
Right. And then there were a few questions like, how often did someone give you a hug when you did something well or you were very good? How often were you told how great you were? And there's one more. And those questions came from the positive influences of childhood, I think it's called, Esther Chung. And those questions, only 3 or 4 questions, made a difference in outcomes in a prospective study of adolescents who became pregnant. And then we thought, we'd like to ask people about some experiences that might be actionable even when the child's small. So we asked about, there were grown-ups who would read stories to me and sing songs. So this is a potpourri of questions that we've put together. They're 10 questions, and we call it positive childhood experiences. So then we are trying to help doctors and have a conversation about ACE and about the positive. And so here's a graphic that we're making available as an option. And the parents' bad experiences are over here where the lightning and thunder and clouds are. And here you're at this juncture with your child. And over here you could go to the sunny side. This is the past. And in this case, having someone sing songs to you and someone hug you was endorsed. So how to introduce this? And by the way, I think many people are not talking about ACE. They're just giving a number, not talking about what actually happened. That's common. But we thought you might say something like, tell parents about the ACE. New scientific evidence shows that stress on young children can cause many long-term medical and emotional problems. And these problems can be lessened by protective caretaking by adults. So we're asking all parents to complete questionnaires about their own past experiences growing up as you did, so I can support you in providing this kind of healthy parenting. Since we all tend to parent the way we were parented, having a new baby is a good time to review what growing up was like for you. Your answers to the questions, that questionnaire show up in a picture. Would it be okay to talk about it briefly? So, and then you might show the picture, or maybe not. And the sunny side of the road shows the positive experience you had as a child from the questionnaire you took, and the stormy side are some of the difficulties you reported. And then if there are any positives, you'd say, looks like you've had a model. It'd be great to pass forward to Johnny. And then some specific things you might say. If there's a bunch of ACE, something like, it looks like you had some rough times growing up that may be affecting your health. You need to take good care of yourself. Johnny is another reason to do so. Let me know if we can help connect you to helping services for yourself at any time. But if they had a 0, you could say, it looks like you're able to avoid some of the major bad things when you were growing up. That gives you a head start in parenting, which is good, but no guarantee. Don't hesitate to call for help when Johnny becomes challenging, as they all do at some point. So we're trying to make a contract with them that we're going to be available. And there's some specific ones. Looks like you've had a model. It'd be great to pass forward to Johnny. Being generous with hugging in the way someone did for you, your baby should give you a lot of practice now. Passing on kind of singing you heard growing up, like lullaby songs. And we're going to be having the option to put these comments in their baby book, their Jadis memory book, that is. And we even have a link that gives them some karaoke lullaby models. And they would get information about that in a little different wording if they didn't experience having someone sing songs to them and so forth. So again, we think this is an ideal time. So the other thing about this 4-week or so visit is here's this contract. This is the moment they're about to experience what? Colic and prolonged crying, and giving some anticipatory guidance. This may be a time. This is when babies cry the most. And I'll just read some of the ways of talking about it here. Having a baby is a very joyous occasion. Taking care of a baby can be really stressful. Unfortunately, in the next few weeks, your baby will be in the most difficult age. It's not teenagers. It's the colicky period when many babies cry as much as 3 hours a day as they go through a period when their nervous system is maturing. That crying is what parents find the hardest part about parenting. Has the crying started yet? The most important thing to know is that it usually takes more than one person to work at comforting babies through all this, using very gentle rocking and shushing sounds. And you might want to go over all the 5 S's. We won't go into them now. The good news is that sometime during this difficult period, your baby will begin to smile, signaling it will be over in a few weeks. Learning how to get more smiles is the best way to help your baby, and what parents say is the best part of parenting. So we're at this crucial juncture, and I believe that at this point when crying is maximal, 6 weeks post EDC, is a time when the milestone of responsive crying, of smiling comes up. And just as you're at your wit's end and parents are ready to throw the baby out the window, the baby cries, and the baby smiles rather. The baby's been crying, the baby smiles, and they save their life. And you don't throw them out the window. And I do believe that this is probably smiling is the life-saving survival skill that is evolved for the survival of babies. I think that, but it's not just my notion. Actually, 6 weeks happens to be the peak of shaken baby syndrome and serious child abuse for babies. So this is the time. And we said that the hardest part's crying and the best part's smiling. And this is this moment where there's a crisis. It's going to be crying or smiling. That's going to get me through. How am I going to get through parenting? And the smile shows up. And then you might want to tell them about the memory book where they could find some information about milestones. And this is if you haven't seen the baby book, the Chattis baby book, this is a place where we put in the best and challenging parts, as well as there are milestones with a place to click to get educational suggestions for interacting with your baby to promote development. Okay, so now that's 0 to 3. We also did this for different questions for ages 4 to 12. this is a context, again, of this priorities type questionnaire. What do you want most to talk to your doctor about at your next visit? Then we added the question, it's helpful for us to understand the child's strengths. Please choose 1 or 2 items from the list below. So here's a list: verbal ability, good looks, math, and we put in the items from the 8 intelligences, if you have been following Dr. Gardner, Dr. Gardner at Harvard, and some others. And so what do you think? Anybody want to guess? What was the most prevalent strength? Anybody? All right, here it is. It is, what was it? It was some abilities, and it was art ability, and there was great personality, just in general, and curiosity about the world, and math abilities. Those were the top abilities that parents picked out. But they were a whole variety of abilities. And then we had asked for other. Was there anything we omitted? Well, parents sometimes wanted to talk about the good memory their child had. And then increasingly, as they got older, that they were helpful. So then we asked, again, for these older kids, what's the hardest part? And we gave a list of possibilities. And and by the way, let me just be clear, I'm talking about Chattis, but it's a pretty simple question. I used to, before we had developed Chattis, I would always ask this. And, this is something that doesn't take technology, right? What's the hardest part about taking care of your child? But we wanted to have alternatives because that would give us a chance to provide these kind of tips and messaging to the parent when we knew what the structured responses were. So here's a long list, and if anybody want to try to guess what's the hardest part about taking care of that preschool child? No? Okay.
It's actually not just preschool.
Well, it's not just preschool. It was, I'm sorry.
4 to 12.
This is 4 to 12.
School age.
4 to 12. I've got my, going preschool onwards. Right. So what was the hardest part? And the hardest part, if you look over here, you'll see that there's managing behavior is here in purple, and in dark blue back here is irritability, temper. It's kind of internalizing things and more externalizing behavior. And you can see the general behavior things tend to go down as you move closer to the teenage years, and the irritability and feelings things tend to go up here. And then what did we miss? And mostly other ways of talking about the same thing. There were a lot more ways of talking about internalizing behavior and behavior problems. And with this information, we have modified the questionnaire to include more words that parents might salute in their child. And you see that hardest parts, you begin to see that disability begins to be an issue as they get older. Being demanding is a big one. So for the school age, there was here about 10 to 14% said there's no hard part. So that means 90, 80, 90% of parents they're endorsing something. They give you a sort of a grist in the mill, that's something to talk about. But again, we're saying, we're open to talking about these things. And behavior problems and internalizing problems are the two most common, hardest parts, and they're about equal in frequency. And mood regulation and learning problems are consistently identified beginning in preschool. And so this is just a way to get a more balanced view of their parenting experience and the child also. And we think that supporting strengths may help buffer weakness in the child. And this may be an important thing that pediatricians could be doing. And we think these questions may broaden the agenda. Teenagers, we're not doing this yet. Here's some ideas about asking them about what aspects of your life are important to you right now. Choose one or two in each area. You can add comments. And we also have one related to their strengths. It is in the context of getting to know the teenager, also being a source, and we're exploring of how to support their strengths, get them involved in some activities, and then when you are able to get to know them and their strengths, then challenges such as depressive symptoms or substance use and so forth become like not just a bad thing to do, but a barrier to get to attaining their goals. So that's the way we're thinking about it. And so I think this is where I stop.
Yeah, I think we pretty commonly ask, what's been the hardest part? We're not seeing families because things are going well. Anybody that comes to see the child psychiatrist, something isn't going well. It's not a normative experience the way it is to see their primary care provider. So asking what's been the hardest part is a routine question for what we do. The other thing I often will ask is, what's been the most surprising part of whatever it is that you're going through? Because that orients me a little bit to what their expectations were and where there's a mismatch. And it may not be that what the child is going through is so problematic, but maybe the expectations were. And so it could be, it's helpful sometimes to know where they feel most unprepared or taken aback by. But we always ask about what's been the hardest part, and then, what's going well. Because again, the families are coming to us in the middle of a problem. So that's a pretty standard question for a child mental health person to ask about.
How do you think this would fit into the training of pediatricians? You've been involved in the training of pediatricians for a long time.
Well, I think the key, if you're thinking about residents, it means their preceptors have to do it.
Right. That's right.
Right?
Yep.
So unless it's being modeled consistently, it doesn't matter what we say they should learn.
Yes.
So I think that's the critical part. I think that gets at how people are framing what's normative and what's problematic, and it's a sort of foreground, background way to think about it. And I think that we always need to be thinking about strengths and weaknesses, or what's going well, what's going poorly, what's hardest, what's easiest. It's not dissimilar, I think, from asking youngsters about school, for example. What's going well at school, what's not, what subject's easiest, what's hardest. So I don't think it's different from other ways that anybody who cares for youngsters, whether it's primary care or child psychiatry, would think about what's happening in a child's world. But I think from an educational standpoint, unless it's modeled, it doesn't become a learned behavior for trainees.
I agree with that. And one thing I would like to mention is that pediatricians have a bad long-term reputation of turning down a parent's concerns by saying, oh, that's normal. And I'm hoping that what we're trying to do here is, if it's hard for you, it doesn't matter if it's normal, it's still hard for you. And here's some ways to look at it and some things to do about it. Because parents are very quick to pick up on having their concerns dismissed. So I think that we're also sort of reacting as an antidote to that idea of dismissing concerns just because you and I, as professionals, know that this is typical at this age doesn't mean that it's not extremely stressful for the family.
Well, as Emily
The
said,
other thing I would say is that, certainly for families that come to see a child mental health provider, they are coming what I think of as belly up, right? They are coming in a vulnerable position because they are feeling unsuccessful in some way. Again, very different from going to a well child visit where they may be feeling unsuccessful, but they may also be feeling quite successful. But nobody comes to the child psychiatrist because things are going magically, wonderfully, right? So sometimes our parents are, in fact, unintentionally, I would say 99% of the time, contributing to the problem. The worried parent who is making their youngster's anxiety worse unintentionally. But I need those parents to very quickly to become part of the solution. And so I need to quickly take them from feeling vulnerable to feeling empowered in some way. And validating their concerns, listening to what they think is the hardest part is the easiest way to turn that around and have them become an active part of the solution rather than just part of the problem.
so what we're saying is that we don't have to wait till they end up in the child psychiatrist's hands, and that this can be done prospectively, and that we're presenting this in the context of this national agenda to say, what can we do about ACEs prospectively and preventively? And Emily says, well, it's not going to happen because their teachers aren't doing it. And so this is when you have a paradigm shift, we're talking about getting the teachers to do it, and how do we sort of deflect the stream of pediatric thinking in a different direction. And so what we've come to is to say, we know pediatricians want to do the right thing. They just always do, and they're always positive. But we're going to give some suggestions at the moment of care, and we're going to have the parents already ask the questions. We're not going to wait for the doctor. I mean, if you're using Chattis, we're not waiting for the doctor to ask the question. The question's there, the answer's there. Here are some ways of talking about it. And we're wondering, we don't have, people might see this as a computer, as a model. And so,
I think that I think this is a wonderful approach to broaden the whole agenda of conversations. And I also want to remind people that parents are getting a lot of information from other people, for example, in after-school programs and other places. Some of them have a positive approach, and I think that people can be working together when we broaden the agenda like this.
they get all kinds of advice, and then we're thinking about these little babies who are crying and they're 6 weeks old. And I think one of the things that we're suggesting is that possibly the primary care doctor says, you're going to get all this advice, but if you call me up, I'm willing to talk about these things. I may not respond immediately, but I'm going to be your partner. And that's the kind of long-term contract that they're not offering at the Minute Clinic.
Exactly.
And that's what we're hoping that could be part of the response to this agenda shift.
Yeah, it's interesting because if we want to just take this to a different level for a minute, smiling and crying are both part of regulation of the child's mood and affect. And some children have an easier time of having a positive affect. And it wasn't that many decades ago that people were thinking that they should do a temperament questionnaire as part of pediatric care. And frankly, I know exactly 0 people who are still doing temperament questionnaires, mostly because there's so many other things they have to cover. But in a way, I think this brings up the topic of temperament, and that is, what kind of kid did you get? And how are you managing and accepting, or let's turn that around, how are you accepting the child's temperament and managing to help modify or help them learn how to regulate their mood? That certainly applies to irritability, temper tantrums and moodiness, which are the questions that are sort of the equivalent of crying for that older age group, that parents actually can do a lot about that, about the child's tendency to be irritable. It's really, they have to be Sherlock Holmes and try to figure it out and try to understand what situations are making their child irritable, rather than just what often happens is they punish them for temper tantrums instead of trying to figure out and console them. Now, of course, remember, I've got a consultation practice too, just like Dr. Frosch. And so I see people who are not managing very well. And so they come in because they have a problem. And there's some education to do to say, how else could you interpret this behavior? How can you figure out the meaning of this behavior? When is it happening? And what are some of the things you found that work? So it's related. I know that there's subsequent questions that Dr. Frosch probably uses too. That the opening is what's going well is only sort of the opening, and then helping them extend the skills that help them have times that are going well to times that are not going well, and making that a skill base.
But a primary care doctor may not feel, and you know, this is complicated with their complicated lives and families, and so some advice on the spot may not make a difference. You know, often, or maybe even usually, won't make a difference. But the idea of acknowledging that, you know, how hard it is, and being empathetic, and at the same time, you know, they've got a difficult kid, but maybe reframing that as, oh, curious kid who's overactive and difficult, and acknowledgement, reframing, and trying to emphasize. So I'm going back to what Kahneman did, is helping the remembering parent to be more positive about their parenting, so that they can remember about this positive thing that happened, even though the moment-to-moment experience has been awful, maybe, or stressful, or at least onerous, as these parents report. So our goal may be a modest goal, but tilting the perception of the parent in a more positive, remembering kind of way. That so this is all part of a project. This and some additional features are a part of a project that we are getting underway called the Family Stress Project. We'll be able to look and see whether it made a difference. And it's not just this; it's also when they do have a problem. They did the ACE questionnaire, and they reported that their mother was depressed. And then they come for a visit, and there's a questionnaire that says, ask them if you're depressed, and then we have to talk about that. And the doctor may forget that the parent, you know, the old-timey doctor would know that the parent and follow the family, and that's continuity, but the computer won't forget. And so
in fact, this mother went through that when she was growing up,
and so
having a depressed parent.
What we're trying to do is give these teleprompters, even for difficult circumstances, to get people started in the conversation, and including something that might have been relevant from their own child rearing.
Great. Any other parting questions? So if you want CME credit, this is the instructions for how to log in to get CME credit. I would also like you to email me, bhoward@chattis.com, saying 2 things you're going to think differently about or do differently as a result of this session. That's my regular assessment questions for the core group. Okay, well, thank you very much for joining us. And